How about some of the other more indolent B-cell lymphomas, marginal zone, Waldenström's? Any data there with the BTKIs?
So there's approval for ibrutinib, both in marginal zone lymphoma and Waldenström's macroglobulinemia. This has been, for these rare diseases, the sort of orphan diseases that are very infrequently studied relative to the other B-cell malignancies, this has been a paradigm shift. Patients with Waldenström's, for example, who are MIT88 mutated and don't have a WIM-like mutation are very, very sensitive to ibrutinib and can do incredibly well, much better than one would have expected from standard chemo plus or minus anti-CD20 antibodies. The same is true for marginal zone, which there are very few drugs that are actually indicated or approved for treating that.
So were those approvals in those rarer subtypes based on randomized data or just activity in subsets?
Activity.
That's important. I mean, it's very hard to do those randomized trials in small subsets of patients.
Correct.
How about the other BTK inhibitors like calibrutinib or zanubrutinib? Anything in Waldenström's?
So there are head-to-head comparisons that are underway in indolent lymphomas as well. For example, zanubrutinib is being compared head-to-head to ibrutinib. Sort of an ambitious trial that we'll be really eager to see the results of.
Okay. Now, how about in somewhat more aggressive lymphomas like diffuse large B-cell lymphoma? Any data there?
So these drugs, particularly ibrutinib, have been studied as single agents. Not very impressive, but maybe a signal that there's activity in the ABC subtype versus the GC subtype of DLBCL. That's led to trials examining standard of care chemoimmunotherapy backbone R-CHOP plus ibrutinib, specifically with a focus on the ABC subtype. Primary endpoint of the trial was reported and not met. It may be that DLBCL is a lot more complicated than we thought. It's probably not just the simple Hans criteria by immunohistochemistry breaking down subgroups. Maybe it's 5 subgroups or more based on more modern molecular methods. And so we may need to refocus. But at this point, the primary registrational trial, the endpoint was not met. And so even in the ABCs across the board, ibrutinib didn't add in terms of progression-free survival. Now, that may be due to the fact that, for example, in younger patients, the AE profile of ibrutinib plus R-CHOP is okay, that patients could tolerate it to get to the point where PFS and EFS were improved. That was the case in subgroup analyses, whereas older patients, that was not the case. But unfortunately, when you design your trial, the primary endpoint is what it is, and retrospectively, you can't then decide, hey, this subgroup did better. Yeah. If somebody said at a meeting recently, and I think this is true, if one subgroup did better and the endpoint is a wash, then somebody had to do worse in order for those curves to be balanced. And so I think we need to keep that in.
Yeah, we definitely have to be very careful about making large conclusions from subset analyses, even though there may be some scientific basis for thinking so. I get why that has to make you a little bit timid about doing it. How about, ibrutinib and R-CHOP, that study didn't meet its primary endpoint. How about the calibrutinib? Is that being added to R-CHOP?
I actually don't know the answer to that question, if there's an ACALA R-CHOP study. Certainly the BTK inhibitors are being added, for example, in mantle cell to bendamustine rituximab, but we don't have those results back either. So I think you have to ask yourself the question: is the treatment paradigm always going to be chemoimmunotherapy has to be the backbone to move forward? I think we're learning, at least from the CLL experience, probably not. In the relapse refractory setting, chemo backbones did nothing to enhance the activity of these targeted agents. Maybe that'll be the case in lymphomas as well, where we really need to think outside the box in terms of pathway inhibition and not necessarily have just throwing something on top of a backbone in order to do better.
And moving past that, how about lymphoblastic lymphomas, Burkitt lymphoma? Any reason to suspect that BTK inhibition may be helpful?
I personally haven't seen a lot of data, positive or negative, reported in the highly aggressive B-cell lymphomas. Certainly, not in the near future. There's no change in standard of care with the addition of those drugs.